So we'll begin with the part 2 of the digestive system where we are going to concentrate on the esophagoscopy, EGD, ERCP and appendectomy. So let us understand these two procedures. One is the endoscopy where we involve the endoscope which enters the body through the natural orifices like mouth, anus or vagina without making external cuts on the skin. While the laparoscope procedure requires the small incision, and through that with the help of trocar probes or grasper needle and forceps, we enter inside the body cavity through the skin in smaller skin incision, and this instrument has the camera so that we can see inside the body and we can do certain surgical procedure. Now we know the GI tract which starts from the oral cavity and ends into the anus, and for the scopy of the upper GI tract, usually we introduce the scope through the oral cavity, and for the lower GI tract we introduce the scope through the anus to see the lower part of the GI tract. So this is very important for you. So let us first see the upper endoscopy procedure, and what are the different scopies that we do it for the upper GI tract. Now, whenever you are coding for the scopies, first of all, one must know why do we do the scopy. Usually, whenever there is some problem with the GI tract, we try to find out the reason behind it. Maybe it could be the bleeding and some other issues with the GI tract. For that, we do the scopies. Now, whenever you are doing the scopy, we must know the approach, whether it is for the mouth or the anus. Now here we are talking about both the scopies, upper as well as the lower. So we need to find out whether the approach is mouth or anus, or sometime we do it through the stoma. That is, we create an opening on the surface of the abdominal surface, and we introduce the scope through that. Then what is the type of the scope? Rigid scope or the flexible or a fiber optic? Most of the time we use now the flexible or a fiber optic. Rigid is hardly used. What was performed? Diagnostic or surgical? Are you trying to view something or are you trying to cure something? And then what did you do with the scopy? Did you just check what is happening inside, or did you remove the polyp, lesion, tumor, foreign body or others, and how it was removed? So if you remove the polyp, did you remove it by hot biopsy forceps or the cold biopsy forceps or the snare technique? Because all these are the part of the CPT code language. And then check the pathology report before assigning the diagnosis code. Now let us understand certain guidelines related to the endoscopic procedure. First of all, the diagnostic endoscopy is always a part of the surgical endoscopy. So do not code the diagnostic procedure separately. So let us say, for example, the patient is having the GI bleeding and the patient comes to the doctor. The doctor wants to diagnose what is the reason behind that bleeding, and he tries to do the scopy. That becomes the diagnosis because he wants to find out the problem the patient is having. Now, when he sees that there is one polyp and that polyp is bleeding, and if they take out the polyp, the patient problem will be solved, and then the doctor decides to cut the polyp or remove the polyp. Then what happens is they started with a diagnostic, but then ended up removing the polyp, which becomes a surgical. That time you will code only for the surgical. Second important guideline is procedure like venous access, infusion, injection, non-invasive oximetry, anesthesia provided during the endoscopy procedure are considered as a part of the procedure. Third is bleeding. If the bleeding occurs as a result of the endoscopic procedure and control of the bleeding in the same session of the other major endoscopic procedure, then it is considered as a part of the procedure, and we don't code the bleeding control separately. But if the bleeding control is performed in a separate session following endoscopic procedure, append a modifier 78. So let's assume the endoscopy procedure happened in the morning for the patient, and in the evening the patient comes again because there was some bleeding and the doctor had to do something to control that bleeding. Then you will have to code the that particular control of bleeding with the modifier 78. Now when the biopsy is performed and followed by the excision and dissection removal of the biopsy lesion, then biopsy is considered as a part of the procedure and should not be billed separately. Always remember, excision or more definitive procedure and the biopsy, if it happens on the same site in the same session, then we only code for the definitive procedure, not the biopsy. Now let us start with the varioscopy. First is the esophagoscopy. What is esophagoscopy? Scope is a visualization, esophagus is a esophagus. So visualization of the esophagus via thin tube like instrument. It could be the rigid and flexible or through the stoma, which is called as a esophagoscopy. So you will have a rigid or a flexible, and if it is a flexible, transoral or transnasal, mostly it is a transoral, and we are trying to see the esophagus. That is called as a esophagoscopy. Now the next important scopy which we are going to see is esophagogastroduodenoscopy. So we are trying to view esophagus, stomach and duodenum, that is the first part of the smaller intestine, and the abbreviation is EGDE. Visualization of the esophagus, stomach and duodenum, a flexible instrument is inserted via transoral route. If the duodenum is deliberately not examined, then we have to append a particular modifier, whether the repeat exam is planned or not. So, when no repeat exam is planned, we append a modifier 52. But if the repeat exam is planned, we append a modifier 53. Now EGD, in the EGD we must check whether the other things like dilation with a band ligation etc. to code appropriate code, because sometimes your code language talks about dilation and band ligation. So by now you know that where the tip of the scope ends, we basically call that particular scopy by that name. Now when I say the word enteroscopy, that means I am viewing the small intestine. Enteroscopy, it is till the jejunum, duodenum, ileum, jejunum and ileum. Till jejunum or till ileum. Most distal segment of the small intestine is examined. Maybe not including ileum or including ileum, but that is called as a enteroscopy. Sometimes the enteroscopy can be done more easily by creating a stoma. Okay, that is create an opening and through that also the scope can be inserted. So here are some modifiers that we use during the digestive system questioning. So the modifier 22, we know that it is the increased procedural service used when significant additional work is required for extensive lysis of the adhesion or due to the obesity. And in the documentation, it will be clearly written that the doctor took additional time. Modifier 51 is multiple procedure used when multiple procedure are performed during the same session by the same provider. Modifier 53, discontinued procedure when there is too much of undigested food in the area to work effectively, or any situation whenever there is a problem with the health of the patient and the doctor had to stop the surgery. Modifier 58 is stage or related procedure or a service by the same physician or the other qualified healthcare professional during the post-operative period. Used when the procedure can only be accomplished in staged fashion during the global period of another procedure performed by the same provider. So, for example, if the patient has undergone the mastectomy and we decide to give the implant to the patient, then in that case, we do not give the implant immediately after the surgery. We may call the patient after 2-3 months and then we give that implant. But it is the part of the, or it is one of the stage of the procedure, that is a mastectomy procedure, that we are going to remove the breast and we are going to give the implant. And this particular procedure is always discussed with the patient earlier. So this particular stage procedure. Then the modifier 78 is unplanned return to the operating room by the same physician or other qualified healthcare professional used when the patient is returned with some problem with that surgery. Okay, so these are very important. This modifier will help you sometimes to zero down your answer fast. Now let us take some example that will strengthen your guideline. The patient was experiencing difficulty in swallowing and feeling something stuck in the throat. The physician has the doubt of foreign body in the throat. He ordered and done the esophagoscopy. No foreign body found in the esophagoscopy and everything is normal. So what code we will write? It is a esophagoscopy, flexible, transoral. It is a diagnostic type because they were trying to diagnose something, but they did not find anything. So we will write 43200. Now the second example, the patient came for a foreign body removal from the throat. The physician was to remove remove the coin by using the esophagoscopy. So in this case, we are going to use the code 43215 because we have removed the foreign body from the throat. So kindly check the code 43215 and you will see that this is the code for the removal of the foreign body by the scopy. Now let us see whether you can get the modifier right. If the physician discontinued the procedure, what is the right way to submit the claim? So the physician has discontinued the procedure. So modifier 53 with appropriate documentation is the first choice. B is the modifier 53 along with the procedure. C is the procedure and appropriate documentation. D is a procedure modifier 53 with appropriate documentation. And the answer is, let's see what's the answer. Yes, so the D is the correct answer because we will write the procedure code, we will put the modifier 53 on that, and along with that we will also submit the appropriate documentation and to the insurance company. So let us take one example. 55-year-old patient was admitted with a massive gastric dilation. The endoscope was inserted with the catheter placement. The endoscope is passed through the cricopharyngeal muscle area without difficulty. Esophagus is normal. Some chronic reflux changes at the esophagogastric junction noted. Stomach significant distension with what appears to be multiple encapsulated tablet in the stomach, at least 20 to 30 of these are noted. Some of these are partially dissolved. Endoscope should not be engaged due to the high-grade narrowing in the pyloric channel. The duodenum was not examined. It seems to be the high-grade outlet obstruction with a superimposed volvulus. A repeat examination is not planned at this time. What code should be used for this procedure? So first of all, this is the case of EGD because they started with the esophagus, they have crossed the esophagogastric junction, they have come into the stomach, but they have not checked the duodenum. And we have the two modifier 52 and 53 that we use it whenever we have reduced the cervix. That means we have not gone till the duodenum and we have reduced the cervix, and 53 is whenever we again plan the re-examination. So 52 is when we do not plan the re-examination, we are satisfied or we have found the answer in this particular encounter only. Now in this case what has happened is they have not planned the further repeat examination is not planned. So we will require a modifier 52. Okay. So now so that automatically eliminate C and D. And let us see between A and B what is the answer. So B is the correct answer. 43241. It is the esophagogastroduodenoscopy that has happened in this case, but they have not checked the duodenum. Duodenum was not examined, and for that we will put the modifier 52 because it is a reduced service. And what is the code 43241? It is a esophagogastroduodenoscopy flexible transoral, and then there is a semicolon, and then I'm going to write with insertion of the intraluminal tube or the catheter, and that has happened in this particular patient. So we will zero down the answer B. So let us take the next case. This is a case of the 78-year-old white female with a morbid obesity that presented with a small bowel obstruction. She had the surgery approximately 1 week ago and underwent a exploration, which required a small bowel resection of the terminal ileum and anastomosis, leaving her with a large inferior ventral hernia. 2 days ago, she started having a drainage from her wound, which has become more serious. She is now being taken back to the operating room. So this is very important. Reopening the original incision with a scalpel and the intestine was examined, and anastomosis was reopened. Excision at both the ends and further excision of the intestine. The fresh ends were created to perform the another end-to-end anastomosis, the correct procedure code. So what has happened is she already had a one excision of the intestine. Bowel is nothing but a small intestine, a small bowel and large bowel, another name for the small and the large intestine. So the resection of the bowel happened and the anastomosis has been done, but now there is a problem with that wound, so she was reopened again, and then they have done again another end-to-end anastomosis has been done. So let us see what are options. So 44120 enterectomy, resection of the small intestine, single resection and anastomosis. Okay, so 120 is the code for that. 44126 is also the enterectomy resection of the small intestine, but for the congenital atresia. Now here there is no mention of such word that the patient had some congenital problem. And 44202, it is the laparoscopy surgical enterectomy. This is nothing, this is not at all a laparoscopy. Otherwise, there was a mention of the word laparoscope, trocar, or the camera. So this is the open method. So we will not take the code 44202, and even the code 44126 is for the congenital problem. That is also not the correct code. So let us see what's our answer. So the 44120 was the right code, and we were left with the two option A and C. So the only deciding factor is the modifier. And if you see 76 and 78, what is 78 is, it indicates an unplanned return to the operating procedure room by the same physician following often due to the complication, that is 78, and 76 is used to report a repeat procedure. This is, though it is a repeat procedure, it is first of all, it is an unplanned return. There was a complication, there was a drainage or the discharge from the wound, and that's why 78 is more appropriate modifier, and we will go with the answer A. A 4-year-old patient who accidentally ingested Valium found in his mother's purse is found unconscious and rushed to the emergency department. The child is treated by the ED physician, who inserted a tube orally into the stomach and performed the gastric lavage, removing the stomach content. What is the CPTA and ICD code? And we have the multiple codes. So first begin with the first column. 43754 is a gastric intubation and aspiration therapeutic. That means they have given certain treatment. Then 43754 is a gastric intubation and aspiration diagnostic. Then 43755 is the collection of the multiple fractional specimen, and 43756 is the duodenal intubation and aspiration, the diagnostic. This happened in the gastric, not in the duodenal, though 756 is not the correct answer. Now in between these three, you will see the second 43754 is a diagnostic. Okay, and in this case they are tried to do certain treatment because they have done the stomach lavage. So in between 43753 and 755, 755 is a collection of the multiple fractional specimen with the gastric stimulation, single or double lumen tube. Nothing like that has happened. So we will have to zero down the code 43753, but we need to check even the ICD code. So the code T40.4X1A, it talks about poisoning by other synthetic narcotics. Because Valium is a narcotic, it is accidental because it was not intentional, looking at the age of the patient, and it is an initial encounter. And R40.20 is an unspecified coma because the patient was unconscious. So B is the right answer. So the next important topic is ERCP, which stands for the endoscopic retrograde cholangiopancreatography. It is the procedure that combines the upper GI, gastrointestinal and endoscopy and X-ray to diagnose and treat the problem of the bile and the pancreatic duct. In ERCP is considered a complete if one or more of the ductal system is visualized, and if they have any problem, we resolve the problem. Now the ERCP is used not only for the visualization of the ductal bile and the pancreatic ductal system, but sometimes we do the balloon dilation and the stent placement if we see that these ducts are blocked. And these are the medical terminology we use it for the bile, bile duct, gallbladder and common bile duct. So the chola is a bile, cholangio is a bile duct, cholecysto is a gallbladder. Remember, cyst is nothing but the sac. So bladder is a cysto. And colodoco is basically common bile duct. So you must know this terminology properly. For the reporting purpose, we use this following tree. That is, for the pancreas, we have the major and minor duct, and for the biliary tree, we have the common bile duct that is here, and then we have the right hepatic and then the left hepatic, which join to form the common hepatic, and this is the cystic duct, and the cystic and the common hepatic, they join to form the common bile duct. Now the ERCP with the stent placement includes the balloon dilation in that duct. So let's assume that we are putting the stent in the common bile duct, and before that we are dilating this particular common bile duct, we will code only for the stent placement. The balloon dilation is included. ERCP with more than one stent placement, that is a different duct or the side by side in the same duct, side by side in the duct, then we report it by the modifier 59. ERCP with a multiple stent placement in the same duct, we code it only once. And ERCP with a balloon dilation of the multiple duct, we will report by the modifier 59. So let us take some example for you to understand it properly. So let us take some example for you to understand this concept. The patient was present for balloon dilation and a stent placement at the right hepatic duct. The physician was done balloon dilation and placed the stent successfully. How you report this service? Now in this case what has happened is they have done the balloon dilation and the stent placement only in one duct. And we have the guideline that when both the balloon dilation and the stent placement, it happens in the same duct, we only code for the stent placement. And 43274 is for the stent placement. Then the next example. The patient was present for the balloon dilation at the pancreatic duct and stent placement at the right hepatic duct. The physician was done balloon dilation and placed the stent successfully. How would you report this service? Now in this case what has happened is there are two different ducts. One is pancreatic, one is hepatic. In the pancreatic they have done the balloon dilation, while in the right hepatic they have put the stent. So I will code it like this. I will write the stent code first, followed by the balloon dilation. Now the third example. The patient was present for the stent placements at right and left hepatic duct. The physician was placed the stent successfully. How would you report this service? Now in this case what has happened is two stents are placed, and which are they? One is in the right and one is in the left hepatic. So I will write the code for the stent, the first stent code, second stent code, and on the second stent code I'm going to put a modifier 59 so that the insurance company will know that this is the stent not in the same duct but in another duct or different duct. Now let us see some question related to this to the topic of GIT. So the patient had a laparoscopic cholecystectomy with a cholangiography. How would you report this procedure? What has happened is they have removed the gallbladder, and then the cholangiography also happened. So we need to check the code. Now 47605, it is the code which says cholangiography. Okay, the cholangiography did happen. But here, below the 47605, there is a note for the laparoscopic approach, C 47562 to 47564. Our approach is laparoscopic. So both the cystectomy and cholangiography happened by the laparoscopic approach. So 47605 is not the correct code, and that eliminate option A and B. So let us see between C and D what is the correct answer. So 47579, it talks about unlisted laparoscopic procedure, biliary tract. Remember, unlisted procedure you will write whenever you do not find any specific code for that particular procedure. So let us see what is 47563. It is the laparoscopic surgical cholecystectomy, that is a code 47562. But 47563, it is a code laparoscopy cholecystectomy with a cholangiography, and that's what happened in our patient case, and we will zero down the answer C. So let us take this example. During ERCP, the surgeon places two stents in the common bile duct and third stent in the right hepatic duct, which is the proper coding. So we have two stents in common bile and one in right hepatic, and we see the option. So they have given only one code 43274, and if you read the language of the code, it is with the placement of the endoscopic stent into the biliary or the pancreatic duct, including the pre and post dilation. And the parenthetical note is given, but luckily none of the codes are there. But it is not that important in this particular example, but never ignore the parenthetical note. Now we have this code, we just need to find out which is the correct way to write the answer. So yes, C is the correct answer, because if the two stents are placed in the same duct, because we have a two stent placed in the common bile duct, it must be reported as a single unit only. And when multiple units of 43274 are performed in an anatomically different site, we append a modifier 59, and the site is right hepatic and the common bile. So C is the correct answer. Now, the next example, a 82-year-old female had a CAT scan which revealed evidence of the proximal small bowel obstruction. She was taken to the operating room where an elliptical abdominal incision was made, excising the skin and subcutaneous tissue. There were extensive adhesion along the entire length of the small bowel. The omentum and the bowel were stuck up to the interior abdominal wall. Time consuming, tedious, and spending an extra hour to lysis the adhesion, to free up the entire length of the gastrointestinal tract from the ligament, to treatise to the ileocolic anastomosis. The correct CPT code. Now let's find out the data. Now this is, first of all, what is it? There is a, what they have done is, the procedure what they have done is a laparoscopic procedure or open procedure. It is the open procedure because I can very well see that there is abdominal incision that was made. So in between the 44180 and 44005, which is the correct code. So the enterolysis, that is freeing up the intestinal adhesion, that has happened, and this is the by open method, while 44180 is a laparoscopy surgical enterolysis freeing up the intestinal adhesion. This is the open method, so we are interested in the code 44005. Now we have A and C with the same code, but there is a modifier that will decide our answer. So yes, C is the correct answer, because it was a time consuming, tedious, and spending an extra hour to lysis the adhesion to free up the entire length of the gastrointestinal tract, and 22 is for the additional service or the additional work that the surgeon has carried out, and for that we will use the modifier 22. Now the next, the patient has an adjustable gastric restrictive device component removed and replaced via the laparoscopic procedure. How should you code this procedure? Now whenever you are solving any question from the gastric or the digestive system, always pay attention whether the procedure is open or whether the procedure is carried out by the laparoscopy. Here the approach is laparoscopy. So now let us see what are the code. 43773, it is the removal and replacement of the adjustable gastric restrictive device component only. Now it is patient has an adjustable gastric restrictive device component removed and replaced. Okay, and then 43772 is only for the removal. Remember, if we have a combo code, we'll always prefer that code. 43888, it is the code for the removal and replacement of the subcutaneous port. It is definitely not a subcutaneous port, but a gastric restrictive device. So we know what's our answer. So our answer is 43773. Always pay attention, laparoscopic versus open, and whether if there is a combo code, that always comes first compared to the individual codes, and those guidelines are the general guidelines that are applicable to almost all the subjects. Now the next important is appendectomy. Now appendectomy is the removal of the appendix. This procedure is carried out by the open surgical method or the laparoscopic. If the documentation includes the term like incision, open, the procedure was performed as a traditional surgical appendectomy. Laparoscopic approach is minimally invasive. So sometimes they will use the word minimally invasive approach, or if the procedure includes the terms like the assisting device, trocar or camera, it is a laparoscopic procedure. Many a time during the APC exam, rather than using the word laparoscopic, they will say that the doctor used the trocar to carry out the surgery. And from that you have to derive the conclusion that this is a laparoscopic approach. Okay, so you have to pay attention to all those important notes. These are the code for the appendectomy, and if you will see that the 44950, it is written only appendectomy standard non-ruptured. So this is the code for the open appendectomy. That means you have cut open the abdomen, or you have carried out the laparotomy, and then you have done the appendectomy. Laparotomy is cut open the abdominal wall and then taking, which is the open approach. Then the 44960 is also appendectomy, but when the appendix has been ruptured. So sometimes they will write the word rupture appendix, or sometimes they will say that there was a severe peritonitis and abscess. So you have to read it carefully. Then 44955, it is appendectomy performed as an additional procedure during another major surgery. So, for example, sometimes what happens is the lady is undergoing the hysterectomy, and by the open method, so many times during the hysterectomy, they take out the appendix. So, what happens is, in that case, you will code for the hysterectomy as well as the appendectomy, because it is written must be listed separately. Then 44970, very clearly written laparoscopic appendectomy. And 44979, it is an unlisted laparoscopic procedure for the appendix. Always this code should be rarely used whenever you are not whenever you are not getting the confirmed code. So let us take some example. The patient is 40-year-old gentleman who presented to the emergency room with a sign and symptom of the acute appendicitis with possible rupture. He has been brought to the operating room. An umbilical incision was made, which is 5 millimeter Versa step. Trocar was inserted. A 5 millimeter O degree laparoscope was introduced. A second 5 millimeter trocar was placed suprapubically, and 12 millimeter trocar in the left lower quadrant. A window was made in the mesoappendix using the blunt dissection with no rupture noted. The base of the appendix was then divided and placed into an endo-catch bag, and 12 millimeter defect was brought out. Select the appropriate code for this procedure. So what is this? This is the appendix operation. How did they carry it out? They carried out laparoscopically. So we have enough information. So let's zero down our answer. So the answer is 44970, laparoscopic surgical appendectomy. Pretty easy answer. Now the patient is going into the OR for an appendectomy with a ruptured appendicitis. Right lower quadrant, transverse incision was made upon entry into the abdomen. In the right lower quadrant, there was a large amount of pus consisting with the right lower quadrant abscess. Intraperitoneal culture, anaerobic and aerobic were taken and sent to the microbiology for evaluation. Irrigation of the pus was performed until clear. The base was the appendix. Right at the margin of the cecum was perforated. The mesoappendix was taken down and tied using O-vicryl ties, and the appendix fell off completely, since it was already ruptured with the tissue paper thin membrane at the base. There was no appendiceal stump to close or to tie, just an opening into the cecum. Therefore, the appendiceal opening area into the cecum was tied twice using the figure of 8 Vickrell suture. Momentum flap was taken over this area and anchored in a place using the interrupted 3.0 Vickrell suture to secure the repair. What CPT code and ICD codes are reported? Now what has happened is here the appendix was ruptured. So we have the code and we can zero down the answer very easily. So 44950 is the code for the open appendectomy. 44960 it is the code for the ruptured appendix. 44970 is the code for the laparoscopy. Now this was not a laparoscopy because I do not see the trocar, I do not see the laparoscope. So this was the open method. So I'm going to use the code 44960. Now what is this code 444905 and what is whether the ICD code is correct or not? Let's see our answer. Yes, so B is the correct answer 44960. It is for the appendectomy, that is a ruptured appendix with a abscess and generalized peritonitis. 49905 is the omental flap, intra-abdominal list separately in addition to the code for the primary procedure, and it is add-on code. So we will have the code prior to that, and K35.33 is the acute appendicitis with peritonitis and with a perforation and localized peritonitis. So all the codes are right. In the new CPT format, CPC exam format, we have the operative report. So I have taken two cases. Operative report is preoperative diagnosis, calculi of the gallbladder. Post-operative diagnosis is also same, calculi of the gallbladder, chronic cholecystitis. That is, there is an inflammation of the gallbladder. Procedure is cholecystectomy. What they have done is they have removed the gallbladder. The patient is 50-year-old woman who has history of RUK pain, that is a right upper quadrant pain, which ultrasound revealed to be multiple gallstone. She present for the removal of her gallbladder. The patient was brought to OR and prepped and draped in a normal sterile fashion. After adequate general endotracheal anesthesia was obtained, a trocar was placed and CO2 was insufflated into the abdomen until an adequate pneumoperitoneum was achieved. A laparoscope was placed at the umbilicus and a gallbladder and a liver bed were visualized. The gallbladder was enlarged and thickened and there was evidence of the chronic inflammatory changes. Two additional ports were placed and grasper were used to free the gallbladder from the liver bed with the combination of the sharp dissection and electrocautery. Cystic artery and the duct are clipped. Dye is injected in the gallbladder. Cholangiography revealed no intraluminal defect or the obstruction. Gallbladder is dissected from the liver bed and the scope and the trocar are removed. What CPT coding is reported for this case? Now, what is important for us is to find out that there is a cholecystectomy happened. How did it happen? By the laparoscopic method, not the open method. And then there is a cholangiography that also happened in order to check the cystic artery. So we have now the enough data. Let us zero down our answer. So if you see the code 47600 and 47605, it is a cholecystectomy with a cholangiography, but it is for the open method. Ours is the laparoscopic method. So we will eliminate the option C and D, and in between A and B, we will have to decide the code. 47562, it talks about the laparoscopy surgical cholecystectomy, and 47563, it talks about the cholecystectomy with a cholangiography. Always we will choose the combo code, and in our case the cholecystectomy happened, the cholangiography happened. But wait, there is a parenthetical note below 47562. It says for the intraoperative cholangiography, radiological supervision and interpretation, see 74300 and 74301. For percutaneous cholangiography, see 47531 and 47532. In our case, it is a intraoperative because during the operation the cholangiography happened. They did not do that cholangiography prior to the operation, but during the operation. So we will check the code 74300, and 26 is for the professional service. So our answer is B. Let us take one more case. The procedure performed is endoscopic retrograde cholangiopancreatogram with a stent placement and enteral biopsy. Indication is 50-year-old male who underwent a liver transplantation for the end-stage liver disease, secondary to chronic hepatitis C and hepatocellular carcinoma 10 years back. The patient has a cholestatic liver enzyme requiring a ERCP before placement of the 12 centimeter stent and to evaluate the biliary system. Description of the procedure: the patient was taken to the fluoroscopy suite in the GI lab where he was found to be alert and oriented. After discussing the risk and benefit of the procedure, the consent was obtained. The patient was kept in the semi-prone position. After adequate conscious sedation, an Olympus sites viewing therapeutic scope was inserted through the mouth all the way to the second portion of the duodenum. Then the common bile duct was cannulated and the cholangiogram was obtained. After the fluoroscopy evaluation of the cholangiogram, a 12 centimeter stent was deployed for the biliary drainage. A biopsy from the antrum was obtained. The patient tolerated the procedure well. There was no immediate complication. What CPT code should be reported? So this is a ERCP procedure where the cholangiogram was obtained in order to check the biliary drainage, and then the stent was put and even the biopsy from the antrum was taken. So we need to now zero down our code. So there are two procedures that has happened. The antrum biopsy also happened and then stent placement also happened. So since the two procedures are done, we will require the modifier 51. So let us zero down our answer. So yes, the B is the option 43274. It talks about the placement of the stent, and that has happened in this case, and 43261 is for the enteral biopsy that has also happened, and 43274 takes the precedence, and then the 43261, and we'll put the modifier 51 on the second code. And here we finished with the all the scopies and with the upper GI tract, and then we will see in the part 3 the lower GI tract scopies, that is a colonoscopy, and along with that the hernia raphe and then the liver transplant.